Good morning, everybody. Today's class we will be discussing about the most clinical relevance of the topic related to renals or the excretory system. So the first topic will be discussing encompassing around diuretics, the drugs which causes increased urine formation, the renal function test, and dialysis in case of treatment of renal failure. So as you all know, the urine volume per day we excrete around 1 to 2 liters per day. If it is more than 2 liters per day, it's polyuria, and if it is less than 500 ml per day, it is oliguria. Whereas between 0 to 100 ml, it is anuria. Polyuria is more excessive urination, with oliguria is decreased, whereas anuria is almost much urine. So diuretics are chemicals that enhance the urinary output. Most of them are not reabsorbed. The substances that exceed the ability of the renal tubule to reabsorb it. The effects of diuretics is increased urine output with decreased blood volume. It is used in hypertensive and congestive heart failure. And the mechanism of action is to increase GFR and decrease tubular reabsorption. It can either accelerate the rate of urine formation, and these are called as diuretic agents, and they are classified under carbonic anhydrase inhibitors, the loop diuretics, the osmotic diuretics, potassium-sparing like spironolactone, thiazide and thiazide. These drugs or thiazide-diuretics are more the first line of treatment for the hypertension. So loop diuretics or the furosemide. So basically, diuresis takes place either with three processes. Either it can be osmotic diuresis. In this condition, urine output is increased due to the presence of osmotically active particles in the filtrate. Reducing sugars in diabetes mellitus produce osmotic diuresis. Whereas increased water intake increases urine output due to reduced secretion of antidiuretic hormone, and this is water diuresis. Whereas the substances which increase the urine output by modifying the function of the nephron are the diuretics. So we came to know what was polyuria based on the volume. It was the increased urine output with reduced solute concentration. Nocturia is excessive voiding of urine during night. It's a common symptom from diabetes mellitus. Oliguria is reduction in urine output less than 400 ml per day. It's commonly seen in renal failure. The absence of urine output commonly seen in shock and renal shutdown is anuria. So, having had the basics of diuretics, now we go into the drugs causing diuresis. So, acetazolamide, the Diamox, is used in the management of edema secondary to congestive heart failure when other diuretics are not effective. Carbonic anhydrase inhibitors are less potent diuretics than loop diuretics or thiazides. They help to make hydrogen ions available for exchange with sodium and water. They block the action of enzyme carbonic anhydrase. As a result, they increase excretion of bicarbonate, sodium, water, and renal potassium. The reabsorption of water is decreased and increased urine volume. The loop diuretics are the bumetanide, ethacrenic acid, the furosemide, and their action is at the loop of Henle. They act directly on the ascending limb of Henle to inhibit sodium and chloride absorption. The loop diuretics are potent diuresis and subsequent loss of fluid. The decreased fluid volume, thereby reducing the BP, the central venous pressure, and reduced left ventricular and diastolic pressure. They are used therapeutically in cases of edema with congestive heart failure and hepatic and renal shutdown, and also used in treatment of hypertension. The osmotic diuretics are the mannitol of the plasma expanders. They work in the proximal convoluted tubule. They are non-absorbable, produce an osmotic effect. They pull water into the blood vessels and nephron from the surrounding tissues. These osmotic diuretics reduce the cellular edema, increase urine output by causing diuresis. They reduce excessive intraocular pressure. Therapeutically, treatment of patients with the early oliguric phase of acute renal failure. They promote the excretion of toxic substances. They reduce intracranial pressure, and they are also used in treatment of cerebral edema. The potassium-sparing diuretics are the amiloride, spironolactone, and the trimetrin. They work in the act in the collecting tubules and the ducts with distal convolution. They interfere with sodium-potassium exchange. They competitively bind to aldosterone receptors. They block the resorption of sodium and water, usually induced by aldosterone. These drugs prevent potassium from being pumped into the tubule, thereby preventing its secretion. They block the aldosterone receptor and they excrete sodium and water. Spironolactone and trimetrin are used in hyperaldosteronism, hypertension, reversing the potassium loss and caused by potassium losing drugs. Amiloride is used in treatment of congestive heart failure. Thiazide, the hydrochlorothiazide, the chlorothiazide, and the trichlomethazide. These drugs, along with metazoline and chlorothalidone, they inhibit tubular reabsorption of sodium and chloride. They act primarily in the ascending loop of Henle. The result water, sodium, and chloride, and the potassium is also excreted. They dilate the arterioles by direct relaxation, thereby helps in treating hypertension. They lower peripheral resistance, and they also deplete sodium and water. They used in treatment of hypertension, the first line of treatment, and in edematous cases and idiopathic hypercalciuria with ADH deficiency resulting in diabetes insipidus. There are adjuvant treatments in cases of congestive heart failure and hepatic cirrhosis. So we go on to the renal function test. The purpose of renal function is to evaluate the general health, diagnosis of disease and disorders related to the kidney and urinary tract, and diagnosis of systemic diseases that affect kidney function, monitoring of patients with diabetes, which causes microalbuminuria, and screening of drug abuse. So normally we do urine examination, blood examination, and renal clearance test. The miscellaneous are the kidney, urinary bladder X-ray, the intravenous pyelography along with the scans and arteriography with finally the renal biopsy. So urine examination, which is the urine analysis. Here the renal function tests such as the urine are used to screen for the cause and extent of renal dysfunction. Consists of the following measurements: the macroscopic, the chemical, and microscopic examination of the sediment. It's yellow due to the pigment urochrome, breakdown of hemoglobin. It's sterile, slightly aromatic, with a pH of around 6, the specific gravity of 1001 to 1035, and the volume is around 1.5 to 2 liters per day. The physical characteristics are: it's clear, pale to yellow deep due to urochrome. The concentrated urine has a deep yellow color. The drugs, the vitamins, and diet can change the color of the urine. Cloudy urine may indicate the infection of urinary tract. Macroscopically, it's yellow strata amber, In abnormal cases, the color can change due to disease, drugs, and diet. It can be pale, amber, orange color, or red green, depending on different cases, like in jaundice, or in drugs like rifampicin and vitamins. The physical characteristics of urine are: the fresh urine is slightly aromatic, standing urine develops an ammonia odor, some drugs and vegetables alter the usual odor. It's slightly acidic with a range of 4.5 to 8. There is a limiting pH. Diet can alter the pH. Specific gravity, as I told you, it's around 1001 to 1035 depending on the solute concentration. The chemical characteristics of urine are: urine is 95% water and 5% solutes. Nitrogenous bases include urea, uric acid, and creatinine. Other normal solutes are sodium, potassium, calcium, magnesium. Abnormally high concentration of any of these urinary constituents may indicate pathology. Disease states alter urine composition dramatically. The nitrogenous waste products like urea, creatinine, and uric acid, and also nitrogen, are resulting from deamination and breakdown from creatinine, phosphate, and nucleic acid. If these substances are found in blood within the normal ranges, this is an indication that kidneys are functioning normally. If blood levels are elevated, this indicates that there is a decreased kidney function, must be diagnosed and addressed soon. The other substances of prime importance are glycosuria with the presence of glucose, proteinuria, indication of damage to the glomerulus, hematuria, indication bleeding in the urinary tract, or bacteriuria with infection. Ketonuria, indication of fats and proteins are being used for energy. And ketosis, which happens in diabetic ketoacidosis, beta hydroxybutyric acid, acetoacetic acid. The typical substances that are tested and which are significant are pH, the acidic status, alkaline indicates old sample and urinary tract infection, specific gravity, the state of kidney and hydration of the patient. Protein detects albumin, important indicator for renal disease. Microalbuminuria is the first cause for the incipient nephropathy, particularly in diabetes. Glucose primarily detects glucose, important indicator of diabetes mellitus. Blood indicator of renal disease, ketone due to starvation and diabetes, bilirubin with liver function if it is deranged, urobilinogen if it is increased amount seen in fever, dehydration, hemolytic anemia, and liver disease. The diagnostic evaluations, renal function evaluates how effective the kidney is at concentration fluids, concentrating fluids and excreting waste. Concentrating ability is evaluated by specific gravity and osmolality. The excreting ability is evaluated by creatinine clearance test. BUN, the blood urea nitrogen, measures the level of the urea in the blood. It's a byproduct of protein metabolism. The kidneys filter out as waste in the urine. The normal BUN, blood urea nitrogen, is around 10 to 20 milligram per deciliter. If it's more than 20, it reflects kidney disease, and less than 10, it indicates liver disease. So the renal profile are the metabolic profile, the BUN, the creatinine, the potassium, uric acid, and phosphorus and bicarbonate. Sodium is around 135 to 145, with potassium being 135 to 145. With BUN, creatinine, with creatinine being around 0.5 to 1.5. The renal clearance is very important because it's the volume of plasma that is cleared of a particular substance in a given time. The renal clearance tests are used in determining the GFR. They detect glomerular damage. They also follow the progress of diagnosed renal disease. The volume of blood plasma cleared of waste in 1 minute by assessing the blood and urine samples. Clearance is equal to UV into by P. The inulin is used for assessing the GFR. It is neither reabsorbed nor secreted. The rate at which a chemical is removed from the plasma. The tests of the renal clearance are the inulin clearance, the creatinine clearance test, the para-immunohippuric acid. The tests of renal clearance used to calculate glomerular filtration rate and tubular secretion. The other investigations are kidney urinary bladder X-ray, the IVP, the retrograde pyelogram, the renal ultrasound, the renal CAT scan, MRI, and a nephrogram to assess the degree of damage, how much functioning kidney is it happening. The percentage of the renal damage can be assessed. The invasive diagnostic tests are the renal angiogram, which assesses the blood vascularity, the cystoscopy assessing the bladder along with the cystogram, and finally for the confirmatory diagnosis with histopathology, it is the renal biopsy. The urodynamic studies that examine the processing of voiding of urine are the cystometrography, the urethral pressure profile, electromyography, urine stream test. In summary, the chemical composition of urine or its around normal output is 1 to 2 liters per day. It is yellowish color due to the presence of urochrome with a specific gravity of 1001 to 1002, with osmolarity of 10 to 1200 milliosmoles, which assess the concentrating ability of the kidney. The pH 4.5 to 8.2. The normal constituents are urea, sodium chloride, ammonia, uric acid, potassium, creatinine, hydrogen ions, and ketone bodies. The abnormal urine if the normal urine contains all these, then it becomes abnormal. That is the glucose, albumin, hemoglobin, bile pigments, excess of ketone bodies. There can be an acidic urine in cases of starvation, protein diet, diabetes, and the alkaline urine in bacterial infection and vegetarian diet. We came to know what are the diuretic agents that accelerate the rate of urine formation. The substances that increase the output of urine by modifying the functions of the nephron, where we came across acetazolamide, the loop diuretics, the furosemide, the osmotic diuretics, the potassium spironolactone, thiazide. All these we came to know. So how they act is by increasing the urine output and decreasing the blood volume. These diuretics are used in treatment of hypertension and congestive heart failure. And the mechanism is to increase the GFR and decrease the tubular reabsorption. So what's dialysis? It's a process by which normal composition of blood is restored. The blood from the patient and the dialysing fluid. The dialysing fluid is a fluid ion composition similar to that of plasma, are passed on to either side of the semi-permeable membrane. The metabolic waste from the blood moved into the dialysing fluid, and the physiological useful substances moved from the fluid to the blood. Later, the blood is reintroduced back into the patient. The process of dialysis has to be repeated periodically. So, the mechanical means of removing nitrogenous waste from the blood by diffusion or osmosis across a semi-permeable membrane into a dialysate solution, prescribed specific to the individual client's needs. There are two types of dialysis, the hemodialysis and the peritoneal dialysis. This is the hemodialysis where it is connected to the arteriovenous fistula, where the radial artery is connected to the ulnar vein. So there is arterialization. The machine is an artificial semi-permeable membrane used for the filtration of blood, and we do need to heparinize, and this is your hemodialysis machine. which is very essential, whether one of them goes to the vein and another one goes to the artery, the impure or the abnormal substances are removed. The treatment of renal failure also involves peritoneal dialysis. It's a mechanical filtering process used to cleanse the blood of waste products, draw off excess fluids, and regulate body chemistry when a kidney fails to function properly. Peritoneal membrane is used as a filter. There is another one called a CAPD, continuous ambulatory peritoneal dialysis. It requires transfer set connected to a bag of dialysate. The dialysate solution remains in abdomen for approximately 4 hours after exchange. The process is repeated 3 to 4 times daily. The advantage is it doesn't need a machine and convenient for travel. The hemodialysis is a process of removing excess fluids and toxins from the blood by continuously shunting the patient's blood from the body to the dialysing machine for filtering and returning the clean fluid to the patient's bloodstream. Usually 3 times a week, 3 to 4 hours, may be performed at dialysis center or at home. The final resort, when everything doesn't, it is the final resort is kidney transplantation. It is a method of long-term management of chronic renal failure. The kidney of the match donor is transplanted to the recipient. If the organ is well accepted, the renal function is restored. However, the common complication of renal transplant is rejection of the transplanted kidney. There is need to use immunosuppressants on a regular basis to prevent rejection of transplanted kidney. The surgical implantation of healthy human donor into the body of the patient with irreversible renal failure. The kidney function restored with a successful transplant and the patient is no longer dependent on dialysis. Donor kidney may come from the living donor, usually blood relatives or cadaver donors, which can be non-living, and matching has to be done.